Here we are. Welcome to London, guys. Welcome to London.
So I'm Athanasios Saratzis. I'm a vascular surgeon. I'm an academic vascular surgeon, whatever that means. So Lorenzo has asked me to talk to you about randomized controlled trials. It's mostly what I do for a living, really. But I want to stress the fact that I'm actually an active clinician. I'm not just, talking about data and that's it. I do spend most of my time treating patients. I'm based in Leicester. And over the next few minutes, I'll try and convince you that the truth is actually somewhere in the middle. We actually need both randomized controlled trials and we need cohort studies or, if you like, registries. These are my disclosures. The main thing here is if you pay me enough money, I can say whatever you like. But most importantly, I don't really have any disclosures relating to registries, RCTs, etc., because practically all of my salary is paid by the UK taxpayer, i.e. the National Institute for Health Research. I was told off a few months ago because I was using abbreviations when it comes to funders by Lorenzo. That was at CISA this year. So whenever I say NIHR, that's the National Institute for Health Research in the UK, which is the equivalent of the NIH. And the NIHR is the biggest funder of things like RCTs, and big registries globally, actually. This is the outline of the next 20 minutes or so. I don't know why Lorenzo gave me 20 minutes and all the other people 30 minutes, but I'll try and do this in 25 minutes. So I'll go through some considerations about RCTs and why they're great, and then I'll try and show you why we actually need both RCTs and registries. And then a few words about where we go from here. The first randomized controlled trial probably didn't take place in 1747, but that's the first one that we know about. James Lind was a nice guy that worked in the Navy back in the 18th century, and in 1747, he practically delivered the first randomized controlled trial. And what he did back then was almost identical to what we do today. The problem was that quite a lot of people in the British Navy suffered from scurvy, which is what happens to you if you don't consume enough vitamin C. So he wanted to come up with a solution. He performed a systematic review. So like I said, he did exactly what we do these days. He looked at all of the literature back then, and he found 6 different interventions that had been described in the literature when people were trying to prevent scurvy in sailors. So he took those 6 interventions that he found in the literature, and he recruited 12 sailors on board HMS Salisbury, and he gave those sailors these 6 different interventions that he identified in the literature. And he wanted to look at whether they develop scurvy or not. And some of them are quite interesting, like 2 spoonfuls of vinegar TDS, 25 drops of vitriol. I think that's the most interesting one. But they were evidence-based. Now, by the end of the week, he found that those who were eating the lemons were actually doing much better compared to the others. So he found the treatment for scurvy by delivering the first documented RCT. But what did he do next? And that's why I'm trying to say that James Lind was doing exactly the same things that we're doing today. He completely forgot about his randomized controlled trial, and then he spent the rest 30 or 40 years of his life making a living by selling the treatments that were shown not to work in his randomized controlled trials. And I think it's practically exactly what we're doing today, like using full metal jackets in people who claudicate without offering them exercise treatment, or using unproven venous therapies on people that haven't really had the chance to have any form of lifestyle changes enforced upon them. So what I'm trying to say here is that we keep making the same mistakes. We're not designing RCTs correctly, and we're not using the findings of our own RCTs. Now, I'm not saying that RCTs are not the gold standard, but you have to use your brain when you look at an RCT. And you have to use your brain in order to understand what the RCT is trying to answer, the clinical context, how patients have been followed up, and the quality of the study. And only then can you make up your mind with regards to whether an RCT is the gold standard or not. And I'm just going to spend a bit of time talking about effectiveness, because there's just no other way you can assess treatment effectiveness unless you do a properly designed RCT. And I keep hearing about effectiveness of PAD or deep venous treatments based on registries. You just can't assess treatment effectiveness using a registry. And that's just common sense. Now, the phases of trials, we start at the very early phases of RCTs, which take about 1 or 2 years, like the phase 1 trials, where we're testing some bonkers treatment that some clever people have come up with. And then we go all the way to the phase 3 and phase 4 clinical trials. And the ones that are pertinent to plumbers like ourselves are the phase 3 and phase 4 clinical trials. And why is that? Because these are the clinical trials that assess treatment effectiveness. And efficacy is very different to effectiveness. Efficacy is addressed by late phase 3 or early phase 3 trials. Effectiveness can only be assessed by a late phase 4 trial, and usually that takes hundreds of participants. Why is efficacy and effectiveness important? Because essentially, what we want to know as clinicians is whether a treatment actually makes a difference or not. And that's called effectiveness. So effectiveness means, does the treatment work or does it not? And in order to do that, you have to compare this new treatment to what you now think is the standard of care. And you need an appropriate primary outcome measure. And unless you do those things, you're only just looking at efficacy. You're not looking at effectiveness, i.e., does the treatment make a difference to the patient? Efficacy-driven RCTs, like 99% of the RCTs that we use to make clinical choices, unfortunately, in vascular surgery, are not designed to answer clinical questions. And I'll give you an example. This is the random stop study that was led by a group of us called our CPAD. This was Kostas's idea. Kostas Stavroulakis is a colleague of mine, used to work with Theo. So we did this study across 20 centers in Europe. 1,500 patients presenting to 20 sites with CLTI over the course of a year. And what did we do? We looked at whether these patients could have taken part in any of the 7 major paclitaxel RCTs that we unfortunately use to make clinical decisions these days. So 1,500 patients across Europe, real-world patients, can they take part in any of the FEMPOP trials looking at paclitaxel therapies? Well, these are the trials. You can find the paper now published in the European Journal. What we're trying to say here is that less than 15% of these patients would have met the eligibility criteria of these efficacy-driven randomized controlled trials. So these randomized controlled trials cannot really be used in order to make clinical decisions in day-to-day practice. And why did they fail those eligibility or inclusion criteria? Mostly because of multiple long-term conditions and mostly because their lesions were very complex. So we can't use those trials for people who have got multiple long-term conditions, and we can't use them for people who have got complex lesions, which is practically every patient with CLTI that we see in everyday practice. So I think this is an important quote. I think it's from Aristotle, if I'm right. So awareness of ignorance is the beginning of wisdom. That's quite important when you're trying to understand research in general, but RCTs in specific. And sometimes we ignore the fact that RCTs are always designed to address the specific primary outcome of interest. And the RCT can only provide a high-quality answer to the primary outcome of interest-related question. All the secondary outcomes assessed by the RCT are only there in order to inform some other minor questions. So, RCTs are designed to address a primary outcome, not a secondary outcome. And that's another pitfall when we're looking at RCTs in the PAD environment. And I'll give you an example why this, couple of examples actually, why this is important. Let's say that you're doing an RCT to look at whether more people die if they've got CLTI when you offer them bypass or endovascular treatment. If you're looking at a difference between 7% and 3% in terms of your primary outcome of interest, you need to randomize 1,500 patients. No study has ever done that in the CLTI environment, apart from BEST CLI, which again was based on a rather different primary outcome of interest. And my second example, I think, is probably more interesting. So let's look at this trial called ISIS-2, published in 1988, Lancet. This trial has informed how we offer antithrombotic treatment to people with MI over the last 4 decades. You can never convince me that we would be able to deliver such a big trial in the PAD environment. So this is a big study, it's a seminal study, and it's definitely well designed. So it showed that if you combine superkinase and aspirin, you get fewer MIs, strokes, and deaths after an acute MI. But look at this table that they published. The Lancet editor at the time kept asking the investigators of the ISIS-2 trial, a fantastic trial otherwise, to publish some secondary outcome measure-related analyses. And the chief investigator at the time said that, yeah, we are going to publish those secondary outcome measure-related sub-analyses only if you publish this table. And what this table shows is that for Libra and Gemini, aspirin doesn't make any difference. So what they're trying to say here is that most of the sub-analysis that we performed, if the RCT wasn't designed to look at that specific question, I'm sorry, but it can't really answer that question. And another example of pitfalls when you use big data in order to address weird questions. So I can show you that I can honestly prove any form of association if you give me enough time and an expensive computer. So what I've done here, this is a paper that we published some time ago now. I got access to the MAS trial data, 26,000 patients, the English NASP program from 2013, 200,000 patients, and I got 649 patients from the Framingham Heart Study who had AAA measurements at some point in their lives. So I used hundreds of thousands of patients to look at whether being born on a Saturday, that's called Sabbatogenmenos in Greek. So in Greek culture, if you're born on a Saturday, you're more likely to have weird powers. I was born on a Saturday.
Me too, me too.
There you go. So I did some fancy analyses and look at what I found. But if you're actually born on a Saturday, then you're more likely to have a cardiovascular event after you've had your aorta measured. Yeah, so like I said, I can prove any form of association if you give me enough data and an expensive computer. So please don't let elaborate statistics fool you, especially when you're using massive data sets. Science requires study design and not elaborate statistics. However, high-quality observational data, if used correctly, can be quite useful. We remember Kostas's papers, a number of them now, showing that paclitaxel might be associated with higher death rates and more amputations, and that's a table from one of his papers. If you look at the latest FDA review in July last year, they've used SweetPad data and some big data sets that were actually showing no associations between paclitaxel use and death or amputations, and then they performed some careful analyses and they showed that the Kachanos meta-analyses were not valid. So, for the Germans here, I hope you can recognize this guy. He used to be a mathematician. His name is Gauss. And what he showed is that the truth is always in the middle. And especially if you use statistics, you will always find that the truth lies somewhere in the middle of that normal distribution. So what I'm trying to say, you need both RCTs and you sometimes need well-designed registry data. So back to randomized control trials. This slide is quite sad. I've been showing it forever. This is the literature with regards to effectiveness-driven, well-designed large RCTs in the CLTI, coronary artery disease and cerebrovascular disease environments. And as you can see, our cardiology colleagues and our stroke colleagues have been delivering those RCTs for years. Unfortunately, there's only been 2 or 3 chief investigators that have managed to deliver big studies in the CLTI environment, like Andrew Bradbury, Alec Farber, etc. And I think we really, really need to change this table and flood that CLTI part of the table with randomized controlled trials. And I think we've started doing that. In the last 2.5 years, these are the major effectiveness-driven randomized controlled trials that we've managed to fund through the NIHR in the United Kingdom. So we've got a trial now for every single vascular patient. And I'm sorry, but I'm going to spend a minute naming every single one of those trials because I honestly think this is what we should be doing in the near future. If you've got a patient with aortoiliac disease and you don't know whether open or endovascular surgery is better, they can go into the EVOQUE trial. Amputation-free survival, 5-year follow-up. Clarity. Any patient with PAD, rivaroxaban and aspirin compared to clopidogrel. That's starting recruitment some point in 2024. EVOQUE is already open. Placement. That's use of local anesthetic or placebo in major lower limb amputations. So does an infusion of local anesthetic make a difference? The MAT trial just funded metformin or placebo in people with small AAAs. LEADER PAD. Does colchicine make any difference to MACE when you've got PAD? That's any patient with PAD. THRIVE just started recruitment last week. The first 6 patients have already been randomized. It's a 3-arm study comparing antithrombotic regimes after you've had a superficial venous treatment of some nature. And finally, EARNEST, hopefully starting recruitment late 2024, intervention or best medical therapy for acute type B aortic dissection. So any vascular patient can now take part in an RCT, and all of these are addressing important questions. They're all effectiveness-driven big RCTs. Another 2 are currently considered by the NIHR HTA at stage 2. Right, so another few things about clinical trials and why recruiting in all of these studies is important. I've heard a lot from various people that medical applied research is just a more controlled version of what we do in everyday care, and therefore we can just use our big data sets in order to address certain questions. Well, that's not true. The other thing that I keep hearing is that it's not okay to test new technologies on human beings. Well, I'm sorry, but we're not the body shop. These technologies and these treatments that we're using, they're actually meant to improve people's health, but they've got certain side effects. And you can't convince me that even a stent should be used without having been tested in a big randomized controlled trial. Then the other thing I keep hearing is that research and clinical care, they're 2 different things. Well, yeah, on paper, yes. Research is supposed to produce knowledge so that we provide better care for people in the future. Clinical care, we need to do the best for the patient that's in front of us. And some would argue that there's a conundrum of those 2 duties of the healthcare professional. So on one hand, we need to provide better evidence for society for the future, and on the other hand, we need to do what we think is best for the patient in front of us. And you might again argue that equipoise only exists when you're definitely certain that treatment A and treatment B is safe enough for the patient in front of you, and you as a doctor thinks that these treatments are the same for that specific patient. Well, yeah, okay, that's the perfect scenario. But we keep forgetting that the standards of professional responsibility as healthcare professionals are social in nature. We're not only here in order to safeguard the interests of the patient in front of us. We're trying to improve the health of society. And in order to improve the health of society, again, I'm sorry, but we need to deliver all of those big studies because the health of society depends on those big studies. So moving on, I'm just going to leave that quote over there. You can find that paper on the New England Journal that was published about 36 or 37 years ago. And what I'm trying to say is that if you are still not in equipoise with regards to all of those big RCTs that we finally managed to fund in the United Kingdom, well, please do read that paper. Equipoise exists at a societal level, and our obligation is that we improve the healthcare of society, not just the patient in front of us. So we need to forget about the unconscious bias that lead us to decide about treatment A or treatment B based on what we think is better. We need to provide an answer based on this effectiveness-driven RCTs about what is truly better for society. So please recruit in well-designed RCTs. It's the only way that we can change healthcare for the better. And don't forget about these studies. If you want to take a picture of that, please do. If you do want to know more about these studies, please stop me and I can let you know how you can open up your site. Thank you very much.
Thank you very much, Thanos. Stay on the stage, stay on the stage, stay on the stage. I think it's a big honor for me. You know, we started this thing last year and we created an award for people that are particularly prominent in the vascular field. And I said, he doesn't know about that, but it's my big pleasure because of all the effort you put in something that probably we generally consider boring and actually, you know, like, yeah, I mean, like randomized controlled trials, someone else can do that for us. And you are the one who's pushing this word for us. And as a doctor, but as a human being, and I think we all should share this kind of view, we're all very proud of what you're doing, what you have done, and what you will deliver in the future with all of us. So essentially, it's my pleasure to give you this little, because I mean, we ran out of money, but like it's still very nice award. Little like so Athanasios Saratzis, it's the Endovascular Innovation Award. And it's my big pleasure.
Thank you.
And I think we all need to clap you, because I mean, the stuff that he's doing, no one else around here is able to do. So you are unique, and for this, like, you deserve all our appreciation. Thanks a lot.
Thank you very much. Am I allowed a hug? Thanks.
Thank you.